Welcome to the University of Pittsburgh's Health and Explainable AI podcast. I'm your host, Jordan Gospore, a health and science reporter. Join me as we cover advancements being made in health informatics and explainable AI for students, researchers, and healthcare practitioners interested in applications of artificial intelligence and machine learning. This podcast is produced by the University of Pittsburgh's Health and Explainable AI Research Laboratory at the University of Pittsburgh School of Health and Rehabilitation Sciences Department of Health Information Management. Headed by Ahmad Tafti, Pitt's HexAI Lab cultivates extramural collaborations with academic institutions both nationally and internationally through its research, educational contributions, and this podcast series.
Hello, and welcome back to Pitt HexAI, a podcast series produced by the University of Pittsburgh's Health and Explainable AI Research Laboratory. I'm Jamie Gramz, your host for today's session. We've got a great one planned and are thrilled to have Dr. Hooman Rashidi join us from the Cleveland Clinic Foundation. Dr. Rashidi is the Vice Chair of Technology, Innovation, and Computational Pathology and Director of PLMI's Center for AI and Data Science at the Cleveland Clinic. He combines his passion for patient care and education with his unique training and experience in machine learning to create innovative new tools and resources that improve clinical practice, research, and education. Dr. Rashidi is a well-known physician scientist, a prolific author, an inventor of multiple AI products, and a gifted educator with numerous teaching awards and educational apps. His efforts in the AI, ML, and digital space are internationally recognized, as evidenced by his numerous invited talks, his various editorial and reviewer roles in this domain, his numerous published key invited review articles, and his continued national committee roles within this space. So, with all due respect, Dr. Rashidi, we are honored to have you on today's podcast. Welcome to the show.
Yeah, thank you so much. That was a very kind intro and happy to be part of this.
So, Dr. Rashidi, it's an honor having you on the Pitt HexAI podcast, and especially at such an exciting time in your career where you're about to transition from one amazing role into another. Can you start off by telling us a little bit about yourself and your role at the Cleveland Clinic?
Yeah, thank you. Here, I'm currently overseeing the PLMI's AI Center, which we're doing some exciting work. Very proud of establishing this AI Center at the Cleveland Clinic. Before this, I was the AI director at University of California, Davis, and professor and vice chair of informatics there. So a lot of the work that we're doing here kind of builds on what we had done before at the University of California. And quite frankly, it's building on things that we've done both at University of California, Davis, and at the Cleveland Clinic, which is my new role at University of Pittsburgh, which I'm excited to start.
Great point, Dr. Rashidi. And, I forgot to mention as part of the introduction, some really big news for those of us that are associated with the University of Pittsburgh and UPMC. We're really excited at the recent announcement that as of January 1st, Dr. Rashidi will join the University of Pittsburgh School of Medicine in the newly created role of Associate Dean for Artificial Intelligence in Medicine. Congratulations, Dr. Rashidi.
Yeah, thank you so much. I'm excited and looking forward to learning a lot and being part of the process.
And your expertise as a physician and also in the field of AI and computer science is really extraordinary. Can you share your journey and ultimately how you got to where you're at today?
Yeah, I mean, it's probably not so different than most other folks in their journey. It just comes from having had great experiences and a lot of support from various mentors and colleagues. And I think it all started before med school, where I was doing bioinformatics kind of work, which back then, that's what we called them. And this was in Doug Smith's lab at University of California, San Diego, and working with him and Dr. Gripskoff, at the San Diego Computer Center. And then that journey led on to me wanting to apply a lot of my, if you will, in quotes, bioinformatics background into medicine. And naively, I initially thought it could be easily, applied to medicine. And as I transitioned, went into med school, wanting to do all of this, I then realized the complexity of, the medical system. And anyways, this over time has evolved into the current state as, these experiences have now, let us know what is it that we need to do to kind of like make the best, most responsible impact within our field of medicine. And really sums up to the 4 branches of medicine, quite frank, which is, we want to improve clinical and quality. We want to do great research. We want to innovate. And all of those actually would not be possible without having the right educational background. So the right education that can support all 3 of those arms. So really the 4 arms of that basically has helped me progress and have made me kind of have these incredible, collaborators that have helped me move forward are really the same 4 arms that, that we apply to medicine.
Well, I really appreciate that, but I think you're being incredibly modest. Pretty rare to find somebody with expertise in one of those 3 fields, let alone all 3 of those fields. I mean, specifically as a physician and as a pathologist, what pathologists do is pretty remarkable. And for those of our listeners that don't have maybe the medical background, could you just give a little bit of insight and explain the role that pathology plays in medicine, both in the anatomic and clinical pathology sense?
Yeah, thanks for asking. I think we're kind of like, we're always been seen as, the physician's consultant, if you will. That's what they've always said in textbooks, So it's like the physicians who are behind the scenes that most people don't hear about. That's definitely true. But I have to say, probably the best way for the audience to kind of get a better perspective of what pathologists do, which is there is a misconception out there that because of, media, that pathologists are only doing a certain type of thing. Most of the time it's around autopsies or CSI type activities, which are great, but that makes up a very small fraction of what a typical pathologist does. So the best way to see this would be the pathologist, and especially nowadays in medicine, everything we do within medicine nowadays is a teamwork approach. So nobody really gets care within a vacuum. And this team, I'll give you a great example. Let's say somebody comes in and they may not feel well within their primary care doctor or the emergency room, let's say. And they get certain labs drawn, and then those labs are basically being taken care of by laboratory medicine, professionals, both physicians and non-physicians, who basically enable the accurate labs to be rendered. And then the clinician, being, let's say, the primary care provider or the emergency room doctor, at that point may look at those lab results and see maybe that the patient has certain findings that are concerning, let's say, for cancer. And then at that point, that particular physician will be getting consults from another physician group, like, let's say, hematologist-oncologist. It's the hematologist-oncologist who then takes the baton and starts running next. And then once they are working up the patient, let's say for this presumed cancer, they will end up getting, let's say, a biopsy to be able to prove that there is cancer. Well, the folks who basically have led to that stage happen to be the diagnostic specialists, which happens to be the radiologists mostly and the pathologists. And so that with that imaging study from the radiologist, followed by the tissue biopsy that had been taken by the hemonc doctor, you now basically pass on the baton next to the pathologist, who's going to render the final diagnosis and potentially also say what kind of a prognosis that particular entity may have. And many of the stuff we do is around microscopes, but some of it is also not around microscopes. It's around molecular studies and whatnot, or a combination of which. HemePath is a great example of this. That's what I do, where, if somebody is suspected of having a hematologic neoplasm, let's say an acute leukemia or, CLL or something like that, it's a multi-step process for you to be able to get that diagnosis, and multiple different disciplines that are involved. And we don't make these final calls in a vacuum, just let's say under a microscope. We combine this with clinical findings from our clinical colleagues, along with molecular findings from the molecular lab medicine professionals, along with what I see morphologically under the scope, it all comes together as one big package to make that final and render that final diagnosis. Because it's a major call for somebody. Because the rule number one we have in medicine is do no harm. So we don't want to overcall things that could inevitably lead to irreversible treatment plans, and that being chemotherapy or surgery and whatnot. So I hope that kind of like it was a kind of a winded response, but it gives you an idea of like that a typical process involves a ton of different people, and it's not a one person show.
Fantastic insight. I really appreciate some of the stories you shared, as a practicing pathologist, not just focused on the AI side of activities, but actually signing out patient cases, reviewing the glass slides under your microscope, and now that transitions to use of digital pathology. You're a practicing pathologist in addition to an expert in the AI field. So it's really impressive. And given your role at the Cleveland Clinic, and with the Cleveland Clinic being consistently recognized throughout the US and even around the world for its expertise in patient care, can you share some of the examples of how the Cleveland Clinic is making use of AI in a clinical setting today?
Yeah, that's a great question. So I have to say, AI in medicine is definitely at its infancy. And part of it has to do with the fact that, and I think most people outside of medicine don't realize this because they don't understand that the data that we have, the information that we have from patients within medicine is not as consistent as the information you have outside of medicine. Let me give you a great example of this is if you are building an AI tool outside of medicine, let's say you're trying to do a self-driving car and you're trying to identify a red car that's you identified on East Coast, you most likely will identify still a red car on the West Coast or even in another country. That's not the case in medicine, and especially it depends to the subspecialty. Different subspecialties, there may be what we call inter-observer variability, meaning that the different experts may actually not end up with the same diagnosis or maybe even same treatment plans. We're trying to minimize these variations, but this is where the practice or the balance between the art and science of medicine still plays a role, where experience is a major thing. That's why an experienced physician who's been around for a long time basically is the one that basically is sought after and consulted, is for those particular reasons. And because of that, whenever we make a final call, we want to reduce this inter-observer variability by making sure that, if I'm going to make a major call and saying somebody has cancer, I want to have another boarded pathologist, for example, review my case as well. So that's a typical practice that many of us follow, which is to minimize this potential inter-observer variability, because our number one goal as what we do is do no harm and making sure that we're doing the best thing we can for our patients. So that kind of gives you a sense of why the data within medicine is very different than what's outside of medicine. And that's actually one of the biggest reasons I continue practicing. The number one reason I still continue practicing is because I want to be able to know on the front line what's really relevant. But besides that, you also are taken more serious if you're a practicing physician who basically are dealing with the day-to-day activities. So then if I'm building a tool, it's going to become a relevant tool that has taken into account my various colleagues' inputs and their involvement. So, because again, the rule number one with whatever we do within medicine, being AI-based or non-AI-based, is our entire field is team-based. And there is no solo work typically. And without it, if you don't do a team-based approach, typically it's not a good thing. Bad things happen typically if you basically deviate from that path.
That's great. And maybe just as a practical example, as a pathologist and the work that you do today to manually review a glass slide under your microscope, compared to how that's going to evolve when you transition to digital pathology and you make it possible for the integrated use of AI. Can you just explain some of the use cases of where AI is going to actually help out in that process?
Yeah, that's a great point. And I didn't answer, by the way, your your main thing, which I kind of deviated on the side. So I apologize for that. So like going back to what you said, like, are there examples of things that we currently use? One of my colleagues, Howard Chen, Dr. Chen, he has implemented an AI triage-based platform for mammograms within our clinic. And that becomes an important thing from a standpoint of both rendering those diagnoses as soon as possible, but also triaging and going after the ones that are in need of an urgent response as soon as possible. So that's a good example of it. Within, lab medicine, for example, we're building tools that can identify contaminations, for example, within samples. So to minimize patients' redraw of blood or making sure that the accuracy of the results are maintained. So these are like some examples of this. Now, going back to your next question, which was, why is this important to actually, let's say, digitize a slide, and how would digital pathology and AI actually have an impact for the humankind and just, society as a whole? And the reason for that is because, and this is something that's also, most people are not aware of this, is that the vast majority of, for example, pathologists who are practicing out there in the US, they're not in an academic settings. They're typically in private settings. So the vast majority of our folks who are practicing are in private settings, and many of them may be the sole pathologist in their hospital system. So they may not have the privilege of being able to get another pathologist to review some of their stuff, to have review concur of their cases. So as you can imagine from what I was saying earlier with trying to minimize inter-observer variability, you can imagine how digital pathology and AI integration can actually facilitate not only things that we do here for increasing accuracy, but also serving as a check or a screener for those in community practice, and ultimately helping the community as a whole to minimizing errors. Our ultimate goal is very similar to other high-level industries, let's say airline industry, where you want to minimize bad effects. You want to do what's best for your end user. And this, in our case, it's our patients. And so for AI, I foresee AI having a lot of potential for not only helping patients, but also, minimizing strain on caregivers, bringing people together. So obviously, these are all the great things that AI will potentially be able to do. But we also have to be very careful of it, because it also has, just like any major tool, that it has strengths, but it also has limitations. So you got to be aware of that as well. So I think education is key for everyone. So the more educated your end users and the public is about these tools, the more engaged they are, the more likely that these things get implemented in the most efficient, ethical way.
That's great. In previous discussions, in addition to your clinical focus, you've talked about your passion and your focus on research, and not just research, but translational research and finding use cases that can actually make their way into the clinical workflow. And you just talked a little bit about, when it comes to healthcare, that data is a key topic. One of the really interesting areas where you're blazing a trail, focusing on earlier concepts, is around the use of synthetic data for creation of models. Can you just give a little bit of a background on what that concept is and the area you're focusing on?
Yeah. Thanks for asking. Yeah, that's definitely something we've been concentrating on heavily on synthetic data. We're definitely not the first ones within this field. We're just trying to be contributing to the knowledge as a whole. But I think it's important for the audience to understand what synthetic data is, because I think there is some confusion around that right now from just various talks that I've had. One is, I think it's important to note that when we say synthetic data, I'm not referring to de-identified real data, because technically, or at least theoretically, your de-identified real data can be re-identified, right? And what we're talking about in synthetic data is basically fake data, meaning that it's probably best to explain this through an example. So imagine I have a data set of, let's say a real data set that was of patients who have heart disease, and certain patients have heart disease positive cases, and some of them are controls that are heart disease negative, right? And let's say we collected, blood pressure, heart rate, temperature, various other, features. This information that we're collecting, we typically put them on the rows, right? Individual patients, each one will be in an individual row, right? So in synthetic data or synthetic data generation, what we're doing is pretty simple. We get the machine to first learn the mathematical relationships and statistical relationships between the features and target, for example, or just the data itself. And then that enables us to pull out some function, some mathematical relationship. And then that, what we call a model, that allows us to then generate new fake, rows, or we call synthetic rows, right? So that ends up basically giving us these synthetic data points that we basically then populate a new data set with. But keeping in mind that collectively, we try to have as close as possible. So the relationship of the synthetic data set to the original real data set is preferably, it should be as close as possible in terms of how they performed if you build machine learning models for predictions, so on and so forth. A lot easier concept set than done, but that's kind of like the general idea. Now, why is that important is because these are the big advantages of having synthetic data. So one is, if you're dealing with real data for good reasons, you have to have, you've got to make sure that you are protecting the patient's privacy. So you have to go through institutional review boards, IRB approvals, and so on and so forth. And also, many institutions may not want to share their real patient data with other institutions because, again, maybe the patients don't feel comfortable about that, and good reasons. But as you can imagine, that also could stifle research and innovation. And so how do you move forward research and make it more efficient, since one of the major complaints from researchers is data access, how fast they can get the data? Because when you do ask for permission to get the data, that whole IRB process, depending on the institution, could take anywhere from a month to 6 months of time. And so if you do have an idea, imagine you're an investigator and you have a great idea. If you're going through the regular process and wanting to test out this pilot idea and it's going to help patients, you now are going to be having to wait for IRB approval for good reason. You have to. And then you may not be as excited 6 months from now or 3 months from now in wanting to do the study. And also, how do you know if your study actually even is worthwhile pursuing? You don't know. You haven't even gotten the data yet, right? But if you have the synthetic data counterpart where it's basically has the mathematical relationships and you're not receiving the real data at all, you could test out your original idea in a much faster pace because you basically are not dealing with real data anymore. So that's the idea around using the synthetic data instead of the real data. So it's great for pilot studies. By no means I'm saying this is a way to replace real data. This is just thinking outside the box, trying to find ways where you still are 100% compliant with all the regulatory measures, but finding ways that could expedite your institution's research and innovation platforms. So that's one big thing. The other things that I would argue that synthetic data could be a major help in is, I'll give you a great example. This actually, I'm kind of taking this from one of my friends, Susan, who basically, she brought it up in terms of a good case, which was a lot of us, if you're an investigator, many of the studies that people do are on rare diseases. And when you're an investigator and you're studying rare disease, there's typically many of these rare diseases, they're not very appealing to pharma and industry to wanting to pursue because they're just not that many of them, right? But it's very important to specific family members or specific populations that are dealing with these devastating processes. So how do you basically expedite things like rare disease? I would argue things like synthetic data generation would be another way that you can move forward with this. And that would be like where you combine things that people have already suggested, meaning people have suggested coming up with a federated way of collecting data between multiple investigators and then sharing the data between the original investigators. Well, if you're dealing with real data, it's going to be very difficult for you to be able to share your data from one real set of patient pool with another set of patient pool. But now imagine you've brought together about 100 different investigators from across the world. You've asked them, instead of dealing with their 5 or 10 patients, give one site, the federated site, that has access to the synthetic data generator to basically be able to make the synthetic form. Everybody submits their data into one site. That synthetic data generated site, that federated site, that creates the much bigger data set that's synthetic data, and then shares it back with those investigators who are experts within that particular discipline. So now you've multiplied your number of investigators who are going to do work within that particular rare disease by 100-folds. And obviously the regulatory measures are much lower because the thing that's being shared back is 100% synthetic. There is no real patient information that's being shared back. But again, this doesn't work for everything. So you got to keep in mind that these are great use cases of it, but just like anything, it's not a quick fix for everything. So we just got to constantly think outside the box. Like, how else can we use different things to kind of make our process go more efficiently? And this is just one of many that I'm just bringing up. And then the last part on synthetic data that could be very useful would be in terms of synthetic data biobank. Imagine you're a site that has now created over a year or two's time 1,000 different synthetic data sets, validated synthetic data sets that your institution has found useful. Well, guess what? That could be of great use to your other institution, outside institution collaborators, or your industry partners that want to basically take it to the next step. And ultimately, that's going to help society as a whole. So that's what I meant by synthetic data. And I do want to emphasize that synthetic data could come in a lot of different varieties. It could be images, it could be text, as you've seen with ChatGPT and so on and so forth. They're not all real, right? It could be tabular data, for example. The example that I was giving was on a tabular data. So again, the synthetic data types may vary, but their limitations might be slightly different from one data type to another. But at the end of the day, I think there is a lot of opportunity here for research and innovation within that space. And this is obviously a lot of people, Gartner and others, have pitched this as being the next wave of data science in the future.
Dr. Rashidi, our HexAI laboratory focuses on explainable and trustworthy AI. Can you share your thoughts on how relevant is explainability when it comes to AI within clinical practice?
So explainability, I have to say, it's important to understand what the end user needs in terms of, or wants in terms of explainability, or maybe the patients in terms of understanding. Maybe they want to know, many of them do, of how this thing worked out. Why did it do the way it did things? I think we want to be careful on that. We definitely want as much transparency as possible in terms of giving us the best results. But we also want to make sure we don't dismiss specific technologies just because we don't understand them really perfectly yet. A great example of this is somebody brought this up at a conference to me, which was they were arguing that, hey, if you use an algorithm like a support vector machine and it's going to give me, let's say, a cancer versus no cancer diagnosis, although I can say even with what we call kernel trick, that could become even more black boxes by itself. But they preferred that over a neural network, a deep learning platform, which they didn't understand anything about it. And that's very true. And personally, I'm on the camp of statistics and reproducibility through statistics. And if I do have a platform that are equal, and I have, let's say, a logistic regression model or an SVM that's giving me similar results to, let's say, a more sophisticated, complex deep learning platform, yes, I will be using the more explainable, the more transparent algorithm on that end. But we're also at a phase where we have realized that certain data types, especially like, for example, text and images, for example, those are great examples of them. They are best suited for deep learning platforms. And if you use more transparent, more explainable algorithms like logistic regression and SVM, they just don't do well. And so you are not doing your end user, in this case, our patients, justice, and by using the subpar algorithm for that particular task, And so, and if the question comes up that if I don't understand it, I don't want to use it idea pops up, you also want to think about that, then that should apply to all humans then. And my point to this gentleman was, if I asked, and I did ask him, I said, what's the color of the seat that's sitting next to you? And he reluctantly gave me the answer. He said, it's orange background. And I said, I'm sorry, until you can officially prove to me that which neuron in your brain interacted with what other neuron that gave you that result, I can't take that at face value. I have to have that proof to understand it in detail. That's the same concept here, where we're making, when a human basically makes a call and says, that's an orange call, and 10 other humans say that's also orange, that's good enough for us, where we say we have reproducibility and statistically we're showing that it's orange. Same thing is true within the neural networks, where if the deep learning platform basically statistically shows reproducibility over and over again, and we show that it's doing a much better job than, let's say, a transparent algorithm, then we would be doing our end users, in this case patients, disjustice in terms of not using the better algorithm, the better method to be able to make the call. So that's another thing to kind of keep in mind. But that also takes us in the whole camp of how much should we, depend on these deep learning platforms, because that's a whole other, I think, discussion, as many of us seen that these things are now starting to make decisions on their own, as we've seen with the chatbots that we have and whatnot, or multimodal platforms. So the question is, how do we use these in the most responsible way? And I would argue that the part that's missing within our world is the regulatory aspect, is we don't have the proper regulatory aspects around these things. And we're treating machine learning AI platforms all as one, where they're not. The things that can make a call by themselves, like a chatbot, they are a different entity. And I'm not saying that they're making a call that can, autonomously do it, although you can get it to do that too. But that being said, so it's important for us to kind of like treat these as, in my world, I like to kind of have strict validations and strict kind of like oversight around these, because I see them as another test. And so if I'm putting very strict regulatory aspects, and there is governing bodies that oversee our, testing platforms within medicine, why is this that's going to make a triage call so much different than a typical laboratory test that has multiple regulatory aspects? So those are things that I think people will start to have the right measures around, but this is kind of like, we're in a whole new phase of AI right now, and there is a lot of unknowns and there's going to be a lot of unknowns to come. So it's exciting, but it's also a little scary, in terms of what's going to happen.
Well, I like your take on explainability, and it makes sense that, traditional models, AI algorithms, the support vector machine example you gave, the relationships between the features and being able to understand what type of an impact that has, that supports the explainability concept. But the benefits that we get from large language models, where you don't have that transparency, relying on validation process and ensuring you're doing it in the right way before it's put into clinical practice, you should alleviate those needs of wanting or needing to have that transparency or that explainability from a feature perspective.
I do want to point out that when I meant there was not transparency, I'm not implying that I couldn't give you which feature was the most contributing to the final target, and which one was the biggest contributor and whatnot. Of course, we can do those. What I was referring to is system as a whole. Like, how do we know, is this contribution of this feature truly, because that's a statistical contribution that we're calculating. How do we know within a complex neural network if that really translates the same way as we basically translated outside of the neural network? These things. But again, lots of exciting things for us to figure out, so that's going to be fun.
Well, really great work, especially on the synthetic data, the research you've done, some of the tools that you've created. It seems like that's really going to increase speed to market, reduce the time necessary to create some of these tools. A lot of benefits, especially small sample sizes where you have lack of data. You talked about rare diseases, pediatrics, some real valuable use cases. But you also talked about generative AI. And I know that's another area that you've been focusing on. Tremendous buzz, a lot of hype in this space, hypersensitivity to it. Can you share some of the work that you've been doing at the Cleveland Clinic and how there's a safe way of approaching it, and maybe just some of the examples of the tools that you're working on?
Yeah, I'm glad you asked that because I think in my head, I don't necessarily want to put generative AI in the same camp as our current traditional machine learning AI platforms that we've had. The reason I'm saying this is because, and people argue on this with me. I mean, I'm not saying that I'm 100% right. I'm just saying this is my view of it, in terms of how I see it. But the one thing that I think everybody will agree is that the transparency, since we're talking about transparency, the transparency and explainability of the performance of the more traditional AI ML platforms. Let's say if I built a machine learning platform, not through generative AI, and it's predicting sepsis patients from no sepsis, or let's say cancer patients from no cancer. Well, that's a classic classification task, supervised platform, where we know the baseline truth. The experts have said these are for sure cancer, these are for sure not cancer. So the machine has learned through what it is. You have a confusion matrix that basically spits out the answers. So you know your true positives, your true negatives, your false positives, your false negatives, and you calculate your classic statistical performance measures that most end users within our space are comfortable with, like accuracy, F1, sensitivity, specificity, ROC, so on and so forth. So that's an example of a traditional machine learning platform that we have been using and we still use, that's very much understood and a great part of our day-to-day thing, because we understand, its reproducibility. It's not perfect, and we still have work to do on its MLOps and other things, but nevertheless, the statistics of it is very understandable. On the other end, on a generative AI side, since 99% of the generative AI is not used to tell you if you have a classification task or not, right? They're not being used to say cancer or no cancer. They're being used to spit out an answer of a sentence type or a paragraph typically, right? Or generate a combination of image and sentence. So anyways, let's just stay focused with just, let's say, a paragraph. Well, you know that if you have a paragraph, the context of that paragraph or even a sentence could be drastically altered with just a single word within that sentence or paragraph, right? So because of that, even though we do have particular performance measures that can assess the large language model's output, like perplexity score, BLUE, and other types of scores that we use, at the end of the day, really the gold standard comes down to the human expert who basically says, yes, this sentence makes sense. It gave me the correct thing. And then if you have enough of them and you've created enough of a data set, then you can get them to match and you can show that it actually works. But then these performance measures, like I just said, like perplexity score, BLUE score, your end users are not comfortable. They're not even familiar with these measures. So that's one thing, is the education needs to also happen around that space. But even if it does, I think just as importantly, it's important for the end users to understand that these are not as reliable of a measure as your traditional statistical ones within a confusion matrix that's spit out. Now, I'm not saying over time it could not become more, it becomes better and better over time, but that's a limitations within the chatbots or LLMs that we currently have in place. Now, that being said, if somebody, and that's where the bigger companies have spent time bringing on humans to make, a call, And that's a variation of validating, or even before that, reinforcement learning with human feedback to be able to say how much this gets better over time. But you're now talking about a general large language model, not a model that's specific to your particular discipline. So if I'm building a model that's particularly specific to my discipline, which we have already, we have one, let's say on hematology, and you've seen it. So it's a pretty powerful model. It can actually predict things well. But the only reason we know that this is doing a good job is because we're getting end user experts who've assessing it and who are telling us, yes, this response looks accurate. Now, in order for us to objectively show that this is actually given us a reproducible result, we will need to then tally all of those feedbacks, then test them out automatically within a response mechanism to see if the actual machine is giving us the over and over the same response over and over again. And these are things that are limitations within the platform that just over time needs to be minimized and automated somehow. We're not there right now, and that's kind of like something that's missing within our generative AI setups. But I think over time, the best thing that people have come up with is, besides the human feedback, is they've come up with a way to get another more superior, in quotes, large language model to become the tiebreaker to actually do the thing. So a lot of people are using GPT-4 to be able to be the one that makes a call of if your response is correct or not. Is it better than this other one or not better than the other one? And so that's where we're at. And that's probably the future in terms of having a large language model or some automated platform with a large language model that's going to be able to make these validation calls. But in order for you to be able to make that, you first have to show that your large language model's ultimate final call and final prediction is going to be just as good, if not better, than the humans or several human experts, which they're not at least in our subspecialty. So there's lots to learn from this, from basically what we're dealing with. And I'm bringing it up from somebody who's as an end user myself of these things in terms of how much can I trust them. So that's one of the main reasons I don't advocate on using these things for patient care at this point. And I think the most responsible way would be to do baby steps of using things, maybe certain operational needs that could basically be addressed. We have done things like educational aspects, which we've gotten help with large language models, or educational material that, one of our colleagues wanted translated in several different languages. And of course, that basically did it in a fraction of the time that most translators can actually perform. But at the end of the day, we still gave those to end user experts within their own particular language to further edit. So what it comes down to is we got to treat this like as a science discipline. So we just can't take their word at baseline, because if we did, we're going to do harm. And the reason I'm bringing that up, and I think that's a very important thing to emphasize, is when you do get a response in medicine from a large language model, that's not the same thing as getting a response from that large language model that's predicting your best movie that you may like from the 90s, or what kind of a food you may like for on the weekend. No harm done typically on those, but you make the wrong call on sepsis or cancer, you're going to really hurt people. And that's our number one job, is to make sure we basically do no harm and minimize risks to patients, and for that matter, even to our caregivers, because all of these things are tied.
Very well said. You talked about being on the infancy of use of AI in clinical practice. It sounds like the right approach of domain-specific, discipline-specific areas of focus for large language models, and maybe starting first with workflow-type problems where they can add value, improving efficiency, but not necessarily taking on the risk of making a clinical decision. Dr. Rashidi, what you've achieved in your career and now in your position at the Cleveland Clinic, most people would consider that the pinnacle of their career. But for those of us that are affiliated with the University of Pittsburgh, we're even more excited about this next chapter. So can you tell us about what's next for Dr. Hooman Rashidi?
Oh, yeah. Thank you so much. That's so kind. So I have to say, first and foremost, I think the one thing that I'm most excited about Pittsburgh is just being part of that system and being part of that process, because that's one of the main places where AI came from, and with University of Pittsburgh and Carnegie Mellon's relationship, there's just so many opportunities of not just to do new things and investigate new domains, but just as important, I mean, selfishly, just to learn. I think that's one thing that I'm really looking forward to, is to learning from the community in terms of what's there. My passion is I love teaching. So one of the biggest things that I'm really looking forward to, and I feel that's a cornerstone of everything we do within medicine in general, especially, is how do we basically make sure that our next generation of our caregivers are well versed within these tools and they're part of this process. So my number one goal, I would say, there would be at University of Pittsburgh would be to concentrate on curriculum development, and obviously starting at the medical school with teaching our medical students and graduate students on what is AI, what are the best practices on AI, what are the limitations of AI. Most importantly, this is similar to the course that we developed here at Cleveland Clinic, which is bring more people to the table who basically usually would not be comfortable coming to the table. Because when people typically think of AI and machine learning stuff, they typically think of us as we're in the back coding and dealing with math, and a lot of people don't like that. And although that may be true especially for the builds and for building new things, I have to say that's not necessarily the case. We're at a stage, especially now, within just what's happening in the world within this space, where every single citizen needs to basically know something about this process. Because the way I envision this is that this is very similar to what happened when we got internet in terms of like the changes. It's actually, I personally think it's going to be a more profound change than the internet, because in the internet realm, the human still makes a decision on what to do next. This now has become almost a self-thinking process that's working with you. So it's making a decision for you for a lot of things. Also a scary thing, to be fair, but at the same time, a lot of opportunity to be able to enhance what we do within patient care realm, within various other healthcare provider well-being realm. There's just so many things that this thing can actually help if it's done the right way. And, because at the end of the day, it's happening. It's part of our day-to-day operations. So I would say that would be my number one goal there, which would be try to share my experiences, try to build a team that can then share their experiences with our students. And just as important, I want to learn from the things that I didn't do, my mistakes from past places. So I have to say, when I built the AI course at Cleveland Clinic, one of the mistakes I made is I did not get as many student feedback initially when we were building the course. And so that'll be something that I'm going to try to do differently this time, where I want this course that we're building there to be something that students have ownership of, and they basically tell us. So obviously we're going to say, these are the things, the basics that you're going to learn, but what is it that we're missing that's important to you? So maybe having surveys that are sent out and seeing if there's a consensus among students that they all felt because of X, Y, and Z that these things were not covered, and so let's cover them. So the take-home point is, it's not going to be a one-person show. It's going to be a team thing. So it's going to be very similar to everything else I've done. I mean, nothing that I've done in my life has been individually. It's always been around just having great people around me who've helped me, support me, and taught me and helped us develop these new tools. So same thing will be around the course thing.
Well, hail Pitt, and the University of Pittsburgh is very lucky to have you. Your passion for education, it's so clear. But this role it's a huge role. In addition to developing and facilitating teaching the curriculum for AI with the School of Medicine, you're also going to serve as a professor of pathology, the executive vice chair for computational pathology, and you're also the founding executive director of the new Computational Pathology and AI Center of Excellence. So maybe two questions. The first is just the concept, the newer concept that you're starting to hear more often of computational pathology.
Yeah.
If you can just explain what that actually means, and then talk a little bit more about this computational pathology and AI Center of Excellence.
Yeah, so the computational pathology in general, so in order for us to be able to do computation, we need to have digital pathology. Digital pathology is the future of pathology. It's the reason, if you're wondering why it hasn't taken ground as fast as, let's say, radiology, is because radiology had become digitized way before pathology. And in pathology, just the nature of the field, because you're dealing with a tissue that first has to be formalin fixed and then cut into slides, you actually have to form physical slides first to then take pictures of, and then that picture becomes your digital picture. And not surprisingly, now that you got a digitized pictures of binary zeros and ones, you now can actually apply AI and various other computational elements around it. So that's where the vision is. And this is under Dr. Liron Pantanowicz, the chair of pathology at UPMC, and Dean and others. Everybody's on the same camp that the future is around a future of digitized platforms. And these new AI machine learning platforms are going to become tools that gets embedded within these digitized platforms that allow us to do things more efficiently and, just as importantly, more accurately. And so that's what it comes down to in terms of where computational pathology falls into space. So that's a strategy plan in terms of where pretty much every major center is going after right now. And over time, I believe, just like any innovation, you will basically initially have your early adopters and early majority, and then over time, the non-academic centers will get on board as well too, especially when there's regulatory measures embedded. So that's around digital pathology and computational pathology. The center is a collaboration between UPMC and University of Pittsburgh School of Medicine in terms of a way to expedite these processes in terms of machine learning and AI within pathology and laboratory medicine. Now, that being said, close to 70%, some people quote, of medical decisions that are made within medicine actually come from pathology and lab medicine data. So not surprisingly, if you do have a center, many of your projects may not be from pathology and lab medicine. They'll be from related or, complementary disciplinary, other disciplines. And this is what we've encountered here. So when I built the center here, initially we were going after pathology and lab medicine, but now many of our projects are with collaborators from surgery and internal medicine, so on and so forth. So same thing will be true there at CPACE, the Computational Pathology AI Center of Excellence. And so CPACE's main role would be to make sure it serves, so obviously it's an infrastructure building first. So make sure that it can serve the needs as a core facility. And what I mean by needs of the investigators, meaning that they can come to us with any kind of a data, text, image, or tabular data, and the center can take care of that. But at the same time, the mission of the center still checks off the four major arms of, the major missions of most academic centers, which is clinical quality studies, research, innovation of new tools, and education. So that, especially that education arm, nicely complements my other role within the School of Medicine, where, obviously they go hand in hand. And there's a lot of other resources within University of Pittsburgh and UPMC that I'll just have to initially kind of learn from the process, that where all of these, as we form a group, we can bring them on together that help expedite this education, innovation, research, quality care process. So that's where we're at in that realm. So I hope that answered it.
Yeah, absolutely. I mean, as a graduate student in the health informatics program and part of the HexAI laboratory led by Professor Tafti, we're thrilled to have you. We're super excited to learn about CPACE and see where it's going. And you talked a little bit about this earlier on, but AI can often get a bad rap in some cases. Just from a hype perspective, are there any misconceptions or myths that you'd like to debunk?
Yeah, I'm glad you asked this. So to be fair, I have to say, as somebody who deals with this day in, day out, I definitely understand people who are worried about AI, specifically generative AI, because I'm scared of it too. There are certain things that we have developed that when we see the responses, we just don't understand how was that even possible, because we did not give the machine what it was looking for, especially within these large language models, like the custom chatbots and everything else, which are somehow tied into either our OpenAI APIs or like in open source platforms like that we basically fine tune and do RAG or ICL type studies on. But that's kind of like the generative AI. Definitely, I think we should be cautious around that and not trusting them just because it sounds like a cool thing to do. So I think that's a very important thing. And just as importantly, this is the time for us to try to put in as much hurdles, if you will, or necessary hurdles around the generative AI, as this is, moving towards the AGI platform, the artificial general intelligence. Because I just think once you get to that step, your control as a human might be drastically diminished, no matter how well intended the human builders are. So that's on the generative AI standpoint of it. So I just say, word of caution that, and I'm not the only one, a lot of people from my community within AI feel the same way, where some people are very kind of a doom and gloom, kind of like, I'm not like Professor Harari, like where I feel it's going to destroy the world and everything else. But at the same time, I do believe in certain things, like people like him and others say that there is definitely dangers in this. And so we got to be very cautious. But that being said, I do want to debunk something. And that's because AI has become a lay term, and in terms of, what it is. And so when people typically think of AI, they put everything we do within AI and machine learning under one umbrella. And I was saying earlier, that's not true at all. That our traditional, approaches that we've been using that actually are not doing self-thinking, they're fully supervised through our platforms, through our direction. Those are very different things than a generative AI platform that we're talking about. So I think, we want to be careful not to put hurdles around something that doesn't necessarily need the hurdles and somehow block innovation for things that are actually in process and moving forward. And so if you do have, let's say, traditional neural network or non-neural network machine learning models that make, let's say, sepsis predictions or acute kidney injury prediction or cancer prediction, these are very powerful things that could help us in our day-to-day operations. They could basically minimize adverse effects to patients. But they are very different things than a generative AI that's basically giving out a very tempting response. And we would say, oh, I would love to use that in my day-to-day stuff. So that's the word of caution. And the question is, when will we be ready to actually incorporate, let's say, something like that in our future in medicine? I would say objectively, as a scientist, I would say the way I would want to evaluate it would be, we would do an assessment to say, if I didn't use generative AI at its current state, what would be the human mistake rate? And when I do use the generative AI, this was my mistake rate, because none of these are perfect. They all have mistake rates, right? They all have error rates. So the question is my error rate that I'm going to get from the generative AI is going to be lower than the error rate that I'm getting from, let's say, 3 human experts that have made a call? Once we reach that stage, then I think it would actually be in the best interest of our end users, in this case patients, that we do use something like that. And I think, like you said earlier, Jamie, which was, that's where the baby steps come into place, where you work around things that are the low-hanging fruits, operational, educational, other aspects. And then as we learn the process and see where these capabilities and limitations are, we then incorporate these in a very responsible, slow fashion moving forward. And then also, we also have to be aware of making sure that we're on track with federal and, regulatory aspects, right? So many of these AI platforms are pretty soon or starting to become under what FDA is labeling as pre-trained change control plan, right? The PCCP. So that's the process, as the name implies, right? It's a change control plan. So that process is a good thing because that basically assures that whoever is the vendor or the creator of these things are continuously assessing these things and making sure that they give you reproducible information that minimizes any side effects to the end user's end goal. And this doesn't apply just to medicine. This is something that could apply to anything, but within FDA's new plan it's something that makes sense because now we're treating these like a laboratory test where it actually should be even stricter than a laboratory test because the machine is actually making a call for you. They're thinking for you. So that'll be my 2 cents. I'm not saying that I'm correct on all of these, and my views on these things have changed over time slightly here and there. I just think with experience, we'll learn more as we learn about these processes as the thing evolves. And we'll just have to make use of them as we see fit within our society. The big thing that I would want to put a word of caution around this is that we also want to be very aware of that these things are not equally distributed amongst all end users. So we are very fortunate in our country, for example, to have access to electricity, internet, all sorts of stuff that gives us access to these incredible platforms. We also want to be thinking about, as we're developing these things from here and in Europe and whatnot, is we don't want to widen the gap between the haves and have-nots and find out that even if we nationally make it that there are human AI-aided humans, everyone is an AI-aided human in the future, and that's great for them, let's say hypothetically. What about countries and places that don't have these resources? And so we want to make sure that AI is helping everything and helping the process moving forward. And I'm bringing that up. I think medicine is a great place to bring this stuff up because our medical students are future leaders within medicine and in healthcare systems, and they need to understand how these things work, and things that happen to patients outside of medicine, either directly or indirectly, will come back and affect their either physical or mental health. And so finding ways where our folks are most well suited to be able to give us best of advice and be able to have the right efficient systems in place and be participants as part of the process, I think that's by far the most important thing, is to force multiply our AI champions. That's what I'll leave you with in terms of the best way for us to move this forward would be finding a ton of AI champions who basically are dealing with various domains of AI, not just innovation of AI, but also builds, but validation, but also ethical, legal, and various other aspects of AI, which is extremely just as important, if not more important.
Yeah, I really appreciate the perspective you just shared there. I mean, we talked a little bit before asking your thoughts on explainable AI. You just shared some key insights on trustworthy AI as well, and taking into consideration bias and social determinants of health. And those are critical factors. And maybe another area where synthetic data can actually help us overcome some of these obstacles. But there's one maybe profound and pragmatic thing that you mentioned there when it comes to large language models and generative AI. And if we have the expectation for perfection, we're never going to get there. If these models can perform better than what we can do on our own as humans, and if we're utilizing them in the right way as clinical decision support, not a replacement for the clinical decision made by a healthcare professional, but as a tool and aid to supplement the information they have when they're making that decision, then it's just a better tool in their bag.
I totally agree with you 100%. I think as humans, we should also learn from our mistakes in terms of when we brought on some of these platforms, and not necessarily generative AI, but similar ones, like let's say the Boeing, episodes, right? Where human was not in the loop within their ML platforms, right? As these various instruments were making decisions. So that would be a great thing for us to learn from, that moving forward, we have to make sure that human is in the loop. Because for things like medicine, it's great that these things can serve as assistants, but at the end, the final decision has to be from your end user expert to make the call. It's a very challenging thing to do because we know as humans, we'll get very much used to various automated platforms and we'll take them as ground truth after a certain point of time. So, but that being said, I don't have a fix around that. I just feel like having human in the loop of an AI process is a must as you're going. I'm not saying for everything, but especially for the ones that are making a call for you, they should not have the final chance to be able to execute the final thing. So if the AI, at least not in the near future, and so if the AI is going to make a final diagnosis, that final diagnosis could just be an assist. So you can almost think about it as having, an assistant in your office who's helping you kind of think through some of this stuff. So maybe you forgot about some key differential diagnosis as you were evaluating a patient or as you were making a diagnosis. And this would basically bring in capabilities that human would not have, and it just enhances their day-to-day activities. So yeah, I definitely think there's a lot of excitement, and I'm excited about it too. And there's a lot of opportunities to come in the near future. But at the same time, we also, as humans, and we just want to be cautious of what we're getting into.
So you've achieved so much in your career already, whether it's the patients you've helped as a pathologist, or all those that you've impacted through education, or the innovation that you've helped foster through your research. It's tremendous. But are there any key projects or initiatives, either on the research side or the clinical side, that you're really excited about, or potentially, if you have goals that you would like to achieve, as in terms of your life's work, is there anything that you're still working towards that you're excited about?
I'll be honest, I never thought about it that way, but I guess my biggest thing would be the people who had the biggest impact on my life were my favorite teachers. And so I would say, when it's my last day on earth, and if I was reflecting back, I would want to be able to say, hey, I tried to basically do as close as possible to so-and-so who was one of my favorite teachers. So I think that's what separates humans from other animals. And that is our ability to teach each other from one generation to the next. The one thing we also want to be careful is that we've now taught a non-human platform to do a lot of things. So that's what I'm saying, we want to be careful about this new platform, because up to this point, all of our teaching has been from one human generation to the next. And now we've basically transferred this knowledge to a non-human entity who's able to make certain decisions for us. But I'm still optimistic. I feel as humans, we've gone through maybe not the same kind of innovation here, because this one thinks, or at least is able to make decisions, but we're able to come through it much better throughout history, I think. So I think I'm optimistic in that sense. So if I can make a small dent in that educational path for the next set of investigators and caregivers, then I'll be super happy. And quite frank, I'm pretty happy right now, with my wife and my 2 dogs. I mean, so but I have to say, career-wise, what brings me joy is my interaction. That's why I've always stayed in academics, is my interaction with students, trainees, fellows, other caregivers, because it's a constant learning opportunity. So that part, I'm at fault. I'm constantly looking of ways of learning something from someone else. And my father used to say the best way is the classic thing, which is, if you really want to understand something, teach it to someone else, because that's when you really know you understand something. And so that's probably part of it has to do with selfish reasons, that learning it better by passing it on to someone else. But whatever the motivation is, I'm happy with it.
We're really grateful for the education. And then maybe just to close things out from an inspiration or maybe a words of wisdom perspective, for those that aspire to follow in your footsteps, follow a similar path, Do you have any valuable lessons learned or advice that you would share?
Yeah, I mean, I would not advise to follow my footsteps. I definitely am flattered that you're saying this, but I honestly wouldn't. I would say two things that I've realized. One is, if you've picked a career path, and especially in medicine, I have to say I am so grateful to be in medicine, because that's been a path that has brought me a lot of joy and satisfaction in terms of my day-to-day activities. So I would say my biggest advice for people who are either entering a journey in medicine or some kind of a healthcare field, even if they're not a medical doctor, they could be from any parts of medicine, because it's a big team that's helping each other. And now this team involves data scientists. So I would say be grateful that you're able to make an impact on individual patients and the society as a whole. And hopefully that will give you enough satisfaction to wanting to get up every day and wanting to come to work, but not as a drag, but rather than something that you're excited wanting to do every day, day after day. And I'm bringing that up is because just like any field, we have ups and downs, and it's easy to kind of get into a trap of, oh, I'm doing XYZ and so has got it much better than I do. But I have to say, nobody's got it perfect, and no single profession is perfect. No single field is perfect. I just think that you should pick whatever that you're happiest with. And if you've picked it and you're happy with most of what you do, I think that should be enough. But again, it's an individual decision that each person has to make for themselves. But if you've taken that path that you're now part of a healthcare system team and you're basically moving things forward, be aware that the healthcare system team no longer is just the physicians. And actually, it's been for a while. It's been a teamwork approach for a long time. And now this new team has new team members, and these new team members are data scientists. So I think that's the new change. So that would be my 2 cents. And of course, I'm saying that because I'm both a data scientist and a physician. So I'm marrying the two together that way.
That's fantastic. So I think in closing, we'd like to say thank you so much, Dr. Rashidi, for the really great conversation and for all the inspiration that you shared. That concludes today's podcast, and we really hope you enjoyed the discussion with Dr. Hooman Rashidi, the new Dean for Artificial Intelligence in Medicine at the University of Pittsburgh.
Thanks everyone for tuning in and for following the show. The Health and Explainable AI podcast is produced by the University of Pittsburgh's Health and Explainable AI Research Laboratory at University of Pittsburgh School of Health and Rehabilitation Sciences Department of Health Information Management. I'm Jordan Gaspore. Thanks for listening.